Our webinar this evening will be covering pancreatic cyst, what is known and unknown. The National Pancreas Foundation provides hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research, advocating for new and better therapies, and providing support and education for patients, caregivers, and healthcare professionals. You can support our mission by volunteering in your community, making a donation, participating in our National Pancreas Bowl fundraiser, or sharing your own personal story. For more information, please email us at chapters@pancreasfoundation.org. For tonight's webinar, please submit your questions in the Q&A section of the portal, and Dr. Park will address those after his presentation. Our speaker this evening is Dr. Walter Park. Dr. Park is Associate Professor of Medicine at Stanford University and Medical Director of the Benign Pancreas Program with Stanford Healthcare. He received his undergraduate degree at the School of Foreign Service at Georgetown University and his medical degree at Johns Hopkins University School of Medicine. He completed his postgraduate training in internal medicine and gastroenterology at Stanford University Hospital and Clinics, where he also obtained a master's degree in health services research. His research interests focus on clinical and translational research in pancreatic diseases with a specific interest in biomarker discovery and validation. He is a principal investigator in the NCI-NIDDK Consortium for the study of chronic pancreatitis, diabetes, and pancreatic cancer, and the NIDDK Type 1 Diabetes and Acute Pancreatitis Consortium. Dr. Park also serves as our medical director for the National Pancreas Foundation in Northern California. I'd like to turn the floor over to Dr. Park, and thank you for your time.
Great. Well, thank you. And thank you to all of you who've taken time out of your busy schedule to be with us today. This program is meant to be an hour long. I'm going to try to, I have some slides that I'll cover over the next half hour, and then hopefully for the remaining half hour, I'll try to entertain as many questions as possible. So I'm going to talk a little bit, I'm going to talk about pancreatic cysts. What I hope to try to do in the next 30 minutes before segueing into questions and answers is to summarize the most common types of pancreatic cysts, highlight the current management guidelines, and discuss some recent relevant research advances. So I guess it starts with, why do we really care about pancreatic cysts? And then the reason is because we connect it back to pancreas cancer. And we used to think that pancreatic cysts were not a very common phenomenon and that they were quite rare. However, our thinking changed over the last 3 decades as we quickly became aware that with improved imaging, be it our CT or MRI, and our more increasing use of it for management and evaluation of a variety of conditions, we were finding that these cysts, in fact, are quite common. So this became a very common incidental finding, and we know that about half of these cysts have potential to become pancreas cancer. And in certain epidemiology studies, it seems that up to 2%, if not more, of Americans over the age 40 will have an incidental cyst found in their pancreas, and that as one gets older by decade, this increases by 2 to 3%, such that by your 80s, if we were to randomly select 100 people off the street who swore they had no issue with a pancreas problem, we probably find 10 to 15 of them would actually have a pancreatic cyst. And these pancreatic cysts, again, are clinically relevant because many of them have potential to become cancer. And the key operative word here is potential, meaning that it could become cancer, but empirically and in reality, what we've learned over the last 3 decades is that the risk of transition to cancer is quite slow. In fact, so slow that although we identify this, and this can be a source of significant anxiety upon discovery, the reality for most people who have these cysts is that it probably won't be something that will truly turn into cancer in their potential lifetime, and we can talk more about that. So the 3 most common types of cysts in the absence of anyone who's had a history of pancreatitis can include IPMNs. It's a big mouthful of a word called intraductal papillary mucinous neoplasms. These are perhaps the most common precancerous cysts. These tend to be seen most commonly in the 7th decade of life, and there's an equal distribution between men and women. They can be seen in the head more predominantly than the body or tail, but frankly, they can be seen essentially everywhere. Mucinous cystic neoplasms is the other type of precancerous cyst that uniquely affects middle-aged women, typically in the distal pancreas or the body or tail. And another type of cyst called serocystic neoplasm is, although we call it neoplasm, and in fact, it's a benign process that rarely ever goes on to become cancer. And if we can accurately tell that that's the type of cyst one might have, we probably don't even need to follow it, and we can reassure you. So these are the 3 most common types of cysts, and I'm going to talk about them a little bit more in detail here. This is a cartoon that depicts the 2 different types of IPMNs, and I'm going to use that abbreviation going forward. The most common being the side branch IPMNs. And I think to kind of put this semantics or this lexicon into better perspective, let's just step back and remind ourselves that the pancreas has 2 objectives. One, it has many objectives, but the 2 primary objectives is that number 1, it's a source of insulin that gets secreted into the bloodstream that helps regulate the sugars in your blood after eating a meal. And number 2, it has this ductal system that secretes pancreatic juice up to 1 to 2 liters a day that includes a neutralizing solution to buffer the acidic acid from your stomach, as well as include a whole cohort of digestive enzymes. And so when we talk about branches or main ducts, we're talking about the ductal system that is a conduit for the fluid to be moved from the pancreatic cells into the intestine. And so when we refer to side branch, we're referring to these kind of branches off the main duct, which is the main highway, or the main limb that goes into the intestines. And the reason why we make this clinical distinction is that we've learned over time that main duct involvement of an IPMN is suggestive of a higher risk of cancer occurring or developing over time. This is the mucinous cystic neoplasm that I was referring to that uniquely happens predominantly in women in their middle age, and it tends to be solitary and tends to be in the distal pancreas. And the current thinking is, and the current recommendations has been to remove these when discovered, not necessarily because there is some understanding that these are at higher risk of developing into cancer. In fact, their risk of developing cancer actually may not be as bad or maybe slower than IPMNs, but it was more from a practical perspective that the favorable location of the cyst in the distal pancreas could be operated on with minimal complications, and this was thought to be curative, not necessarily because this was thought to be a more aggressive type of cyst with a higher chance of becoming cancer. And that thinking has permeated now in our thinking, such that for some of these, we're actually following them as a safer measure than operating on them. As I said, the other type of cyst that if we can diagnose is a very benign cyst, which has no malignant potential. And if we can properly make that diagnosis, we can reassure a person and send them on their way with no concern that cancer will develop in that cyst. Now, sometimes these do get operated on, not because of a concern for cancer, but primarily because they grow to a point where they actually cause pain and discomfort due to a mass effect. And in those situations, we still will recommend an operation. So it is, although we don't know for sure, it is estimated that approximately 15% of pancreatic cancers that we see perhaps arise from one of these cystic precursors, the IPMN or the MCN. And that brings us back to, again, to why we're even having this conversation today. Now, as these are increasingly being discovered, and we've had 3 almost decades of observation, we've also had opportunities to create guidelines. And the intent of the guidelines is to advise and recommend physicians and providers on how to best manage these and how to manage them consistently so that we can minimize heterogeneity in practice. And there's been a lot of interest in this, which speaks to, I think, its increasing recognition seen in the population. And we have over 5 or 6 different guidelines out there. And while they're more similar than different, and they all generally recommend some form of surveillance, often with MRI because it's relatively non-invasive. And because these imaging tests are fairly standardized and reproducible, and you can see them in all types of general routine clinical practice. Now, I'm not going to go into all the different guidelines. That's beyond the scope of today's discussion, but I just wanted to show you an example of one of the guidelines that exists that kind of walks a provider or a patient kind of through an algorithm of how we would probably manage this. And basically, the idea is when a cyst is present, you ask, are there certain features that we know are associated with a higher chance of cancer being present at the time of discovery? And if not, which is usually the case in the vast majority of patients, then we move on to a surveillance where you can see in the bottom row some recommendation of following a pancreatic cyst, typically by MRI, CT if they can't take MRI, or EUS if it gets to a certain size, and the rate and frequency of follow-up is really based on this guideline on size. So as I said, MRI is perhaps the most common recommended imaging modality that we recommend, primarily because MRI has very good soft tissue contrast imaging. It can delineate fluid structures like a cyst very well. There's no radiation. And so this is an ideal non-invasive test that could be used repeatedly over time to track the progression or development of a pancreatic cyst. The only downside is, frankly, the cost. It's more expensive than a CT scan and more expensive than an ultrasound. And so what do we look for when we do MRI? We look to see how large the cyst is. A cyst that's greater than 3 centimeters falls into a category of worrisome. Now, again, that doesn't mean cancer is imminent. It just recognizes that this cyst might be at a slightly higher risk than a cyst that's small and much smaller than that. We look for little growths that might be growing along the cyst wall, and we call these enhancing mural nodules, or thickened enhanced cyst walls that might suggest the beginnings of a small cancer that could be developing off the wall of a cyst. Cysts that cause dilation of the main duct due to compression can be of concern, or the duct dilation of the main duct could also suggest main duct involvement, harking back to what I was alluding to earlier about main duct IPMNs being associated with a higher risk of developing into cancer. We look for any abrupt changes in the main pancreatic duct and maybe distal and maybe atrophy or thinning or wearing of the pancreas that might suggest some type of obstruction of the main duct drainage system. You could see if there are prominent lymph nodes on the MRI around the pancreas. If a blood test is taken, but this is not routinely recommended, of a serum CA19-9, then perhaps you may be a little more worried. And if the cyst seems to grow over time, typically greater than 5 millimeters over 2 years, these kind of fit into the current category of ones we'd be a little bit more worried about than others. And then there are some other features where, if seen in a person who is otherwise a good surgical candidate, then perhaps considering an operation. The benefits of MRI is that they're non-invasive, there's no radiation, as I alluded to, and there are standardized protocols. So if you generally get an image in one facility, you could take it and have it reviewed by another clinician at another facility with an expectation that, for the most part, there shouldn't be any need to repeat the MRIs. But there is some variation between facilities and MRIs, so that's not entirely across the board. Some of the limitations of MRI is, while it is very good and there's no radiation, as I mentioned, it is somewhat high in cost. Some patients have difficulties tolerating this because The tube is quite small and some patients get claustrophobic, and you do have to lie still, sometimes for up to 30 to 40 minutes so the proper images can be obtained. Now, if a cyst shows some worrisome features on these current guidelines, many of them recommend considering an endoscopic ultrasound. And this is an endoscopy where a camera is placed through a person's mouth while a person is sedated, typically by an anesthesiologist, not typically breathing on your own, where a camera through an endoscope is passed into the stomach, and the pancreas happens to lie just behind the stomach wall, as well as the first part of the intestine. And at the tip of the endoscope is an ultrasound probe where you can then directly visualize the pancreas in great detail. You can also then use a needle, and under ultrasound guidance, you can use a needle to puncture the cyst and drain fluid and often send it for tests that may give you some further clues about the nature of the cyst. And we'll talk a little bit more about that. So what are the benefits of the endoscopic ultrasound? Well, it has high sensitivity for diagnosing cancers as well as thickened walls. There's no associated radiation. And as I mentioned, you can use a needle to take a biopsy or aspirate the fluid for analysis. And more recently, we've seen that you can even use these needles and not just aspirate fluid for analysis, but you can actually put other devices through it that might give us some more information. I'll talk briefly about some of those technologies. Its limitations is that, well, it is relatively invasive. You do need an anesthesiologist. You do need to be put to sleep so you can tolerate the procedure, but it is an outpatient procedure. You don't stay overnight. You go home the same day. With endoscopic ultrasound, unlike MRI, although these are done by trained physicians, there can be some variability in terms of what is seen based on how the scope is navigated along the stomach and small intestine. And these are relatively high cost procedures. So this is an example that I was alluding to before about traditionally we can put a needle in and then we can suck some fluid out. But on the research front, several of my colleagues across the country have been very excited about this technology where rather than just suck fluid out and send it for analysis, you can actually put a needle into the fluid that is a mini microscope. And you can actually look at the cyst wall lining in real time. And with enough experience and practice, you can make a diagnosis of the type of cyst that you're dealing with. This has been studied at several different centers, and it shows a very interesting promise. Some of its limitations, however, is that you do need a slightly bigger needle, and that might limit how flexible it can be to get into certain types of cysts based on where they're located. And there is a slightly higher risk of developing pancreatitis, which is a severe episode of pain after the procedure that might actually hospitalize you. And this happens in about 4% of patients. This is just another example of what could be done through the endoscopic ultrasound, where you can actually place a needle that actually opens up into forceps, and then you can place those forceps against the cyst wall and actually take a little pinch biopsy, and that might actually give us a more reliable tissue diagnosis. Now, this has been studied, and it's definitely feasible to do, and it's still under research, and it's not necessarily something that most centers do currently, but it is something that is being studied with some potential promise that some centers might be able to offer you and give you more information about the cyst type. Traditionally, and where there's been a lot of research has been on pancreatic cyst fluid biomarkers, where we often will aspirate the fluid and send it looking for proteins, DNA, RNA, tumor markers, and the idea being that the material that is shed into the cyst is unique to the cyst biology, and therefore it would be potentially easier to find a marker that would help us determine if a microscopic cancer is starting to form. And FNA, fine needle aspirations, where needles are put into the cysts, are done fairly routinely, and it's fairly accessible and relatively safe. And these are examples of current tests that your doctors can actually analyze the cyst fluid that's collected. Cytology, tumor marker CEA, DNA mutations, and glucose. And I'll touch upon each of them briefly. So cytology has been around for quite some time, where basically what you're doing is you're taking the fluid and you're spinning it down and looking for the cells that may have been shed into the cyst fluid. Originally, this wasn't thought to be too helpful because the cyst fluid often didn't have a lot of cells or viable cells that the cytologist or the pathologist would feel comfortable to make a diagnosis on. I think over time, as cytopathologists have gotten used to the paucity of cells, they've become more comfortable, however, making diagnoses with fewer and fewer cells, such that cytology does have some use as a potential test that your doctors could send for. It turns out sugar levels in the cyst fluid might actually tell us whether the cyst has potential to become cancer or not. And this is some research that my own group did several years ago. We were looking for novel biomarkers and that may diagnose cancer. And while glucose doesn't diagnose cancer, it seems to be quite easy and cheap to do. So some of the doctors who you might get care from may actually be doing this currently. They can provide this information fairly rapidly and fairly quickly. And it has some good discrimination ability to determine whether this is a cyst that has cancer potential or not. And the performance of the glucose marker is very similar to this test that's been around for almost 2 decades, which is a tumor marker, which is measured in the cyst fluid and has been the one that most people have probably gotten. And they perform very similarly, and they also have the same limitations in that they can tell us whether this is a cyst that has potential to become cancer, but it's actually not very good at telling us whether it is cancer. Now, I think what used to be the future in research is now here, and that is the use of DNA fluid analysis, which has actually been published and reported as far back as 15 years ago, but it had been mostly relegated to the research phase. But I think now we're at a time where this should become standard of care, where we can measure DNA mutations discovered in the cyst fluid. And the power of the DNA mutations is that they can, with high sensitivity and specificity, basically tell us whether an IPM is present, and with about 80% accuracy, begin to tell us whether the cyst is an advanced cyst that has a higher chance of becoming cancer in the near future. And so this is something that I do commonly in my practice now when I analyze a pancreatic cyst and do endoscopic ultrasound. This is really my first test that I will do to get the most amount of information. Beyond that, there's a lot of exciting biomarkers that are out there potentially, but not yet ready prime time for clinical testing. Some are DNA methylation markers. So this is actually not a DNA marker, but the proteins that often connect and bind to the DNA that are methylated. And some of these differences of what gets connected and not is often can help discriminate, particularly the cyst that may be imminently becoming cancer. And this is just an example of a group's work from led at the Mayo Clinic, where they identified 2 potential types of methylated markers off the DNA in the cyst fluid that could be used, and future validation is underway. One of the things that we've been interested in is looking at more trying to discover novel proteins. And so there's many ways that one could do protein biomarkers research on many different types of platforms nowadays. And this is just an example of one where we use a specific type of system to identify novel proteins and to identify and make sure that it truly is there. This uses a system that links kind of DNA fragments, and then through a technology called PCR, will amplify it so we can have higher levels of confidence that if a certain protein is in the cyst fluid, it really is there. But again, this is just meant to be an example of some of the research that's going on, that's still ongoing to look for new tests. So I'm gonna wrap things up here and just kind of give you an overview. I hope I kind of summarized the basics of the cysts. the kind of the essence of the current guidelines that some of you may have come across as you or a loved one have been told that you have a cyst in your pancreas. But I think where we're going with this is that, these cysts, while the vast majority of them you really do not need to worry about, because even though they may be precancerous, their risk of actually becoming cancer in the near future is frankly low. That doesn't mean you can forget about it. And our ultimate goal is to try to find among the few who will go on to develop cancer, we want to find it early. We want to find it so that we can remove it before it becomes a pancreas cancer that would be very difficult to treat. And I'm excited to see that we have many potential technologies that hopefully in the future, in the near future, will enhance whether we can diagnose these early, beginning with MRI and CT based technologies. As I mentioned, these are kind of the workhorse of how we follow these cysts. There's a lot of interested researchers trying to take advantage of machine learning, artificial intelligence, and techniques to perhaps see things that the human eye may not so quickly appreciate that might further risk stratify or diagnose an early cancer. And I think this is an exciting avenue of research that I think will bear out more, in part because we do so many MRIs anyway. So I think we have the substrate and the infrastructure for this, and I think we'll see this research bear fruit in the next 3 to 5 years. When we do endoscopic ultrasound, I think there's a lot more we can potentially do. We can start routinely using contrast enhancement that might potentially help. I pointed out some of the technologies like the confocal microscopic imaging or the biopsy forceps. I think those are some exciting new things that could potentially change how we practice. And there are other potential ways we can even use artificial intelligence and other things about measuring the pancreas stiffness that might give us some more information about the risk of a pancreatic cyst becoming cancer. But again, these are all avenues of research. As I mentioned, the ability of what we can do through a needle is also improving. There's a lot of exciting research in the cyst fluid tests biomarker space that might give us more precision diagnosis of when a cancer is a cancer or when an early cancer is present. And eventually, right now the current goal is to diagnose an early cancer and have that person undergo surgery, a curative surgery. But hopefully in the future, we might even see a time when we can actually adequately treat this by endoscopy, whether it be through an alcohol ablation or a chemotherapy ablation, or even some type of ablation or burning through heat that could potentially reliably burn and destroy the cyst wall and treat the cancer without having to do a surgery. So I think that's about 30 minutes about kind of an overview, intentionally meant to be short and brief so that if there's questions, we can talk more about that. So I'm going to go ahead and look at the Q&A. I see that there are some questions here. I have a cyst that is blocking the main pancreatic duct to the point that a stent cannot be placed. So what happens to the enzymes and insulin being produced by the pancreas if the fluid can't get out? This is a question by Greg. So it partly depends on how severe the obstruction could be. Oftentimes there is a blockage and it can be quite tight. However, most likely there is probably some enzymes, some pancreatic juice that is probably getting out, but perhaps not sufficiently. Now, in regards to the insulin, well, insulin doesn't actually come out through the duct channels. That gets secreted into the bloodstream. So that's not as relevant. But in general, what happens despite these blockages is that there is some amount of fluid that can get by. However, having said that, if there is a severe obstruction, what we do see over time is as the duct cannot adequately drain, there can be a buildup of pressure, and this is often associated with some atrophy of the distal pancreas. Now, while that is perhaps concerning, an operation, having pancreatic enzymes it is not absolutely critical that you have a pancreas to potentially survive. So there are ways around that. As I'm thinking a little bit more about your question, if the cyst is truly blocking the main pancreatic duct, causing it to be dilated, one might think, without knowing all the details of your case, and to be clear, this forum is not meant to go over individual cases, but I'm going to take whatever questions you ask and just kind of throw out the generalized concepts. In general, if there is a cyst that's causing a duct to be obstructed and the doctors are confident that the cyst is a precancerous cyst, that often can be an indication for an operation. But doctors may not do so if they don't necessarily think it is that type of cyst. Let's go on to, let's see, another question. Some hospitals add up the total cyst area and other track individual cysts. Are there pros and cons? So in general, what a radiologist does is they'll document the number of cysts. Now, in some cases, there's so many that they won't count the exact number. And sometimes there's a conglomeration of cysts where they'll describe it as one cyst with multiple cysts that make up for it. And that often can be seen in a main duct IPMN. If you see multiple separate distinct cysts, in the absence of someone with a history of pancreatitis, that often is consistent with multifocal IPMN, multifocal side branch IPMN. And then what you want to focus on is whether the duct is dilated and how big the largest cyst is and whether any of the cysts have mural nodules. Patter has asked, what does methylated or methylation mean? So this again gets back to this kind of the attachment of a sugar to a DNA, which plays a role in DNA biology. So this methylation is just part of the biological process of how DNA gets processed and proteins get made. And it turns out that methylation patterns of what you see on the DNA, these are actually unique and can be a form of a way to discriminate pancreas cancer from non-pancreas cancer. Does draining fluid from cysts help to stabilize the pancreas and reduce pain events? I've had cysts drained and have experienced 16 months. So I think one thing I haven't talked about is, I spoke about the three most common type of cysts, but the cysts I didn't talk about that Greg could be referring to, and again, I'm just going to try to keep this as generalized as possible, are pseudocysts. Pseudocysts, by definition, aren't cancer, but they're a culmination or a consequence of people who've had pancreatitis, where fluid and swelling accumulates because of the pancreatitis. And then as the body heals, it organizes the fluid into a collection of fluid, and it looks like a cyst, but it's not a cancerous cyst, or it's not a cyst that harbors a risk of cancer. And oftentimes those will resolve and drain on their own over time. But if they're so big that they cause discomfort and pain, it's quite common for physicians to put a stent in to drain it entirely and keep it in to allow that cyst to heal. Now, in the non-pseudocysts, in patients who may have large, what we think are precancerous cysts, draining cysts don't necessarily draining cysts rarely offer therapeutic benefit in those situations, because oftentimes once you remove that fluid, the fluid will reaccumulate in a matter of days to weeks, because you're not really removing the source of the cyst fluid, which is really the cells that are secreting the cyst fluid. All you're doing when you put a needle in and taking the fluid out is just removing the product of the cyst cell, of the cell secretion. So for the precancerous cysts, when you do drain the fluid, you're really not doing it for pain relief, you're doing it for diagnostics. But very big cysts that often are pseudocysts, when you get drained, they can cause pain, they can relieve pain. What percentage of cysts cannot be surgically removed? That's a difficult question to answer, because it really is a case-by-case question, case-by-case scenario. Frankly speaking, most cysts, if it's appropriate to be surgically removed, could be, but some of the bigger questions is the patient for who has the cyst, are they surgically fit enough to undergo surgery, which is a big question from many surgeons, because the ultimate goal of surgery is to help a patient. And if it's thought that it's not going to help a patient because if there's a concern of cancer and it's spread, we wouldn't necessarily do an operation. Or if it's thought that the patient, him or herself, is so frail that they wouldn't tolerate a major surgery, then it won't be done. So it's theoretically any cyst could be surgically removed. The question is whether, again, it gets back to whether it's appropriate to be removed, and whether the patient's surgically fit, and whether the cyst is a type of cyst that really needs to be removed. I think I answered John Rokenbrod's question about the difference between a pancreatic cyst and a pseudocyst, and that a pseudocyst is, pseudo in the word is not really a primary cyst. The wall of the cyst is basically scar tissue from an episode of pancreatitis, whereas the wall of a pancreatic cyst is made up of cells, and it's those cells that are the precancerous cells that we're monitoring. Let's see, are there any symptoms that indicate a precancerous cyst other than tests like an MRI or CT? Not really. The most common reason why these cysts are discovered is incidentally. Oftentimes a patient will get a CT for a kidney stone, or they'll have some vague abdominal pain that eventually goes away. That was probably some dyspepsia, and then the cyst has been discovered. And oftentimes the patient is not really having any symptoms. In terms of symptoms, sometimes if the cyst is big enough, it can cause early satiety, it can cause some nausea, it could cause some stomach pain, but these are cysts that are generally fairly big, on the order of 5 to 10 centimeters large, where we would expect it to have some type of mass effect that could affect a person's ability. Now, sometimes a cyst could be compressing the main duct, as I alluded to earlier. That might prevent the drainage of fluid, so some people may develop diarrhea because they're not adequately producing pancreatic enzymes, and that could lead to some weight loss and some bloating, and oftentimes that would lead to imaging where you might see a cyst during that evaluation. In terms of how often an MRI should be done, that really depends on the cyst size, the cyst characteristics. Generally, anything under 2 centimeters without any kind of other worrisome features could probably follow generally once a year. Anything bigger than that, depending on other characteristics and also the person who's having the cyst. In other words, is the person a surgically fit candidate versus a very frail 90-year-old who you're not sure you'd offer an operation anyways, then you could tailor it to somewhere between 3 to 12 months. An attendee says, I have a 3 centimeter mucin producing IPMN cyst in the main duct. The ducts and cysts walls are normal and the size hasn't changed in 3 years of monitoring. I've been advised to have the cyst laparoscopically removed. I was told the surgery itself is low risk, but that I will have to be in the hospital for a week afterward. Okay. So, I mean, this question basically, to generalize this question is, it sounds like the patient has, based on some features, the surgeon is, or the team taking care of this patient is recommending an operation. The rationale behind it is that perhaps even though it hasn't grown or changed in the last 3 years, it's of a certain size that may warrant risk of cancer in the future. Now, again, I don't know all the details. What I would say is, in general, before considering a surgery like this, it's always important to get a second, maybe even a third opinion at other high volume centers, just to make sure that everyone agrees that a surgery would be indicated. So that would be my first advice, because it's not clear based on the details provided here whether you would really need a surgery. But again, I don't know all the details and I'm not asking for all the details. This is just a general discussion. I would just say that if one team has suggested surgery, regardless of whether you agree or not, I would definitely recommend getting a second opinion, just because it wouldn't really hurt, and you'd probably want to, for peace of mind. Now, in terms of surgery, pancreatic surgery, as far and as our surgeons have come over the last generations, it is safe, but it's still major surgery, and you may need to be in the hospital anywhere from 3 days to 7 days, depending on the technicalities of the surgery. A Whipple operation will definitely probably keep you in the hospital longer than a distal pancreatectomy. So not all pancreatic surgeries are the same. And so this is, again, another reason why I would say that even though maybe in this case it is appropriate to get a surgery, at least get a second opinion where you have the opportunity to ask these questions as to how long the recovery would be, and also what kind of surgical technique they might do. Are they recommending a Whipple? Are they recommending a distal pancreatectomy? Can they do it laparoscopically? Can they do it robotically? How many cases they've done? What are their complication rates? What are their recovery rates? These are the things that you should probably go in and ask so you have peace of mind. I have a branch IPMN. I'm also diabetic. Does diabetes increase the chance for cancer? It's an interesting question that we don't fully know yet, but the preliminary data doesn't seem to suggest so as it pertains to cysts, but diabetes is a risk factor in general for the development of pancreas cancer, and new onset diabetes, meaning diabetes that's developed within the last 3 years, there is a little blip where your risk of pancreas cancer does go up because in a subset, a very, very small subset, about maybe 1 to 3%, that diabetes may have been triggered from an incipient small cancer. The question as to whether having IPMNs and diabetes therefore changes your surveillance probably doesn't change your surveillance. It probably does increase your risk a little bit more, but not in a meaningful way yet that we can actualize in terms of our surveillance strategies. In other words, I wouldn't necessarily say, okay, because you have diabetes, we're going to reduce the frequency of doing or increase the frequency of MRI surveillance from 6 months down to 3 months. We don't have that data to show that it's helpful. But it is a risk factor, and it's something that we probably want to keep in mind, but all the more reason for you to just stay compliant with the current guidelines for surveillance. Is nutrition a consideration in terms of calming cysts or slowing down growth? So the short answer is we don't know that question. We don't know the answer to that question. I will say that, in my opinion, that there are certain foods that can be a little bit more stressful to the pancreas, specifically fattier foods. And I think what I do counsel my patients for a variety of reasons is that if you have a pancreatic disorder and you're trying to minimize the stress on your pancreas, I in general recommend adhering to a low-fat diet and trying to keep the portion control to small to moderate at any given time. As I think this will minimize the stress of the demands, the digestive demands being placed on your pancreas. Now, whether that actually calms your cysts down or slows down their growth, we don't have any evidence to suggest so. So that's more general recommendations for someone who might have an underlying pancreas disorder. Pancreas cancer is considered one of the hardest cancers to treat, primarily because of the late stage that it's diagnosed in. Up to 70% of patients with pancreas cancer are diagnosed at stage 3 and 4. And that's what makes it so challenging. It's the overall tumor burden and the spread of the tumor. And this is why early detection matters so much, because we do know that if you can diagnose pancreas cancer at stage 1 or stage 1A, the 5-year survival is in fact 80%. And for patients who have pancreatic cysts that are being followed where they become cancer, and when operated on, the 5-year survival is essentially 98%. Now, once it becomes an established cancer and becomes advanced or locally advanced, it becomes harder to treat. So this is why we are trying to stay diligent and focused on screening and surveillance of high-risk populations for early detection. Okay, I think I've answered all the questions that I can see in the QA. I guess I went pretty fast, but I will hang out here for another couple of minutes. If there are other questions, we can go over them. I thought all the questions were great. Thank you for your interest and enthusiasm. These are very common questions that I get also from my own patients who I see in the clinic for this. Okay. I got a thank you so much from Patter. You're welcome, and thank you for having me. It's been a privilege and an honor to be a part of this, and I hope this was helpful for you guys, and thank you again. I think I'll sign off then, Trish, in the absence of any other questions.
Great. Thank you so much for your time. And this video will be recorded and put on our YouTube page, but I want to thank you, Dr. Park, for your time and for supporting NPF and our mission. Thank you so much.
Great. Thanks again for having me.
Thank you.
Bye.